If the extensive PML prolapse is there, then triangular resection will cause something called as a curtain effect, which will further increase the mitral regurgitation. In this condition, we have to do a quadrangular resection. Uh, Either it can be a symmetrical or asymmetrical, as shown in the diagram D. In conditions wherein the PML prolapse segment is less than 20 mm, then we have to go ahead with quadrangular resection. And as shown in the diagram D, we have to take a annular stitches and we have to approximate, that is called as annular plication stitches, and bring the annulus together, and then taking a interrupted sutures as shown in the below diagram with a 4O proline and close the defect. And any remaining defects should be closed with 5O proline sutures.
If you do a quadrangular resection, you may have to combine it with a sliding annuloplasty, because it causes concertina effect in the annulus, and then it causes distortion of the posterior leaflet. So invariably, triangular leaflet resection is easily done, but quadrangular resection should be generally followed with a sliding plasty.
Yeah. Okay, sir. If the prolapse segment of PML is more than 20 mm, that is 2 centimeter, then horizontal triangular resection of the PML has to be done near the annulus. The continuous 4O stitches should be taken to approximate the leaflet to the annulus. Each, that is sliding maneuver, sir, as you told. This is the sliding maneuver which has to be combined with the quadrangular resection. This is the annular stitches to reduce the annular height. Annular stitches taken along with the triangular posterior leaflet resection with the sliding plastic. And this is the annuloplasty stitches for reducing the annulus to get a proper adequate coaptation. For type 2 commissural or bileaflet prolapse, we have to combine all these techniques, whichever is feasible for the particular defect. If there is a commissural defect with caudal rupture or caudal elongation, the limited prolapse has to be taken care with a triangular resection with annular stitches to reduce the annulus. This is the Mugwon stitch for a limited prolapse, which is not most of the time used. So for extensive prolapse resulting from the caudal rupture, we have to resect the segment with the annular plication stitches with. If the prolapse is more than 10 mm at the posterior commissure, then a quadrangular resection and a sliding leaflet technique is used. The P3 segment, and if necessary, a few millimeters of A3 are detached from the annulus. Whenever distended, the commissural edges of the anterior leaflet is treated by an elective triangular resection to restore the tension. Compression sutures are placed to reduce the gap. Leaflet remnants are secured to the annulus while exerting a traction on the leaflet tissue to facilitate the sliding. 1 or 2 stitches are used to reconstruct the surface of coaptation, leaving the commissure open. Then the remodeling annuloplasty is done. Sir. If there is an extensive prolapse because of the caudal elongation, which is mainly because of Barlow's, as described earlier, we have to use a papillary muzzle sliding plasty or a muzzle shortening as shown in the below diagram. In bileaflet prolapse, we have to use the combination of the described above methods to reduce the prolapse. In techniques of type 3, that is diastolic restricted leaflet motion, which is mainly because of the rheumatic heart disease. First, we have to do these are commissurotomy, caudal resection and fenestration, and ring annuloplasty. In commissurotomy, we unfurl the anterior mitral leaflet, which gives us the landmark of a posterior commissure and anterior commissure. Then, just 5 from the annulus, we start an incision towards the commissural, towards the orifice. Uh, and near the orifice, if we find a chordae which is thickened, then this chordae has to be split in such a way that either cut margin should be there on the either side of the uh, cut part of the commissure. And following that split to the papillary muscle in such a way that it should admit an extremity of a cardiotomy sucker. Continuing that below, if there is a thick chordae below the leaflet, that is secondary chordae, it has to be treated with a fenestration, as shown in the figure F below. That has to be fenestrated as a triangular and should be split, made an independent chordae.
This is quite difficult because you have to have absolute control on your knife. If you go, if you are a little rough, you may detach the chordae from the papillary muscle, and then the whole operation is a waste. So you have to be very careful. Think twice, measure thrice, and cut once.
Yes, sir. So the annular deformation. Ring annuloplasty. Ring annuloplasty is not necessary whenever the ventricular function is preserved. The most of the time, classic ring of a same size is used. Most of the surgeons will undersize, but what I have asked, spoke to the consultants, they use the same size of the AML, sir, AML height. The preferred physio ring is used. Ring smaller size than 30 in females and 32 in male should be avoided. So in type 3A valve regurgitation, the A2 pre-margin has to be secured with a neocordacer. This already has been described with it. If the MS with A2 prolapse is there, then caudal reposition, if it is possible, we can do so. Leaflet thickening, retraction, and calcification with a leaflet extension, which was described by Shumway, and first it was used by a fretter, in which the diseased part of the posterior mitral leaflet is resected and then augmented with a glutaraldehyde treated patch. This glutaraldehyde is treated 10 minutes in a 0.6% buffered glutaraldehyde and rinsed in a saline for 5 minutes. So as shown in the figure, we have to use the glutaraldehyde patch. It should be augmenting the posterior mitral leaflet and annuloplasty ring is applied. Similarly, if AML is affected by the rheumatic heart disease, then after filling, we have to give a transfer or vertical or a transverse incision, and accordingly the patch size is selected and augmented with a patch. So remodeling annuloplasty after augmentation of either AML or PML augmentation with pericardial patch. So these were the last. Previously, we have asked questions were there in the previous class. That is mitra clip and size of the valve which is selected. Most of the time, RST will use the same size most of the time or undersized. Very less likely undersized. In degenerative diseases, most of the time a same size is used. Ischemic undersizing is better. But recent consensus says that ischemic MR, most of the time, MR and mitral repair, mitral valve replacement and repair have no comparison. There is no comparison actually. And butterfly resection and diastolic mitral valve repair. So mitra clip, there are five percutaneous repairs wherein edge-to edge repair is most of the time used, which is the surgical, which is following the principle of surgical repair by Alfrey. Then a coronary sinus root mitral valve repair, LV reshaping, that is approximating septal and lateral wall for approximation and improving a leaflet coaptation, transventricular approach for mitral annuloplasty, and implantation of artificial chordae. So edge-to-edge repair, that is mitra clip method, mainly using a Alfred stitch. It has got a FDA approval and CE mark approval in 2019. The indication mainly it is in primary and degenerative MR, which is having a high surgical risk, and those secondary MRs with heart failure, which has failed goal-directed medical therapy. Mainly, this method is contraindicated, wherein the heart valves having endocarditis, rheumatic mitral valve, or IVC, femoral vein, or any intracardiac evidence of thrombus. Eligibility criteria according to echocardiography, it should have a coaptation length of more than 2 mm and depth of less than 11 mm. Mainly through the right femoral approach, femoral vein route, this steerable guide catheter of mitra clip is introduced using the transfemoral route by echocardiography guidance transeptally into the LA. The clip delivery system can be introduced to the guide catheter. So this is the whole device on which the mitra clip device is mounted. Procedure is divided into 4 steps, that is transeptal puncture, advancement of steerable guide catheter into the LA, advancement of the clip delivery system into the LA and positioning of the mitra clip below the mitral valve leaflet, grasping of the leaflet, assessment of the result, and clip release. So in transeptal puncture, we have two, before going through the procedure, we'll have a video, sir.
Before you went on to mitra clip, you should have talked about the principle of the Alfieri stitch and why it came about, how it helps, and then that is the original surgical procedure, and the mitra clip was a borrowed idea from the Alfieri stitch. You should understand what are the pros and cons of the Alfieri stitch. You didn't talk about that. Okay. Go back and read about Alfieri stitch.
Yes, sir.
And when it is used, when it is not used, and why it has not become very popular, because these are all suboptimal procedures, just like one quick fix type of thing. The bottom line, all these interventional things are for high risk surgical patients. If a patient is fit for surgery, these are not to be used. Remember that.
Yes, sir. This is the mitra clip device, sir. Through the femoral root into the IVC and then into RA, transeptal puncture, showing indentation in the interatrial septum, then puncturing it, then a dilator. Now through the devices, through the transesophageal echocardiography guidance, Not going too deep into the LV, otherwise we'll catch hold of cordace there. After confirming with a transesophageal echocardiography, the device is deployed.
కాదు ఇవన్నీ అరగంటలో అయిపోతాయి. ఒక్కోదానికి ఒక అరగంట చదివితే 4 ప్రిన్సిపల్స్ వచ్చేస్తాయి.
So that was a tent-like indentation which I have seen in the image in the video. And 4 to 5 centimeter above the mitral annulus, we will give a puncture. While it is lesser in functional MR, that is 3.5 centimeters above the annulus plane. This is the tenting which is seen in the interatrial septum, 4 centimeter above the annulus. Through the TE guidance and the fluoroscopy, the guide wire first passed and it is parked in the left upper pulmonary vein. And further, after that, we'll pass the mitral clip device. So grasping of the leaflet, assessment through transesophageal echo and fluoroscopy. So this is the 3D echocardiography of final deployment of the mitral clip from the left ventricle side. This is the complication post mitral clip deployment.
Spend more time on that. Go back to that slide. Spend more time on this so that
Yes,
these are the things that you will have to tackle after they create a problem.
Okay. Most of the time, because of the allergy to the mitral clip material, that is latex or nickel alloy, there might be an anaphylactic reaction. Cardiac perforation, if they are not guiding the catheter properly or the deployment of the device done properly, there may be a embolism of the mitral clip if they have not clipped the mitral leaflets adequately. So might get a stroke or a embolism phenomena, and thrombosis of implant, and there might be a single leaflet device attachment, which is also called as SLDA. So too many complications is going on. So one more thing that was asked in the previous class, that was butterfly resection, which was proposed by Toru Asai. This method was used mainly when the PML prolapse is more than 15 mm, in which resection of the anterior posterior mitral leaflet is done as shown in the figure on the right side, and the below triangle resection is done, which is brought to the annulus with a foro stitch and sutured interruptedly with prolene. The one more thing that I want to is explain in this class was Medanta correction. That is the diastolic mitral repair, mainly for a rheumatic heart disease. Medanta correction, that is having using 3 principles, mainly in RSD, that is showing anatomical and functional obstruction. Even after anatomical adequate commissurotomy, functional obstruction may persist. So both anatomical, that is secondary orifice enlargement, and functional, that is hinge door movement, corrections are required to achieve a reasonable orifice area. So doming, according to this concept, doming means obstruction. Leaflets are not required for the diastolic function, that is passage of the blood from LA to LV. They are only needed for the valve closure, that is during systolic function. Presence of the leaflet is obstructive to the mitral flow unless the complete movement of the valve is there as a hinge door mechanism. So residual post-op doming indicates the residual obstruction. Restoration of the hinge door movement is the ultimate goal of the diastolic mitral valve repair. So obstruction in mitral stenosis is both anatomical and functional. Merely removing the anatomical obstruction will not result in fully opened valve. There is something called as anatomical obstruction and functional obstruction. So there are three orifices as shown in the diagram, that is primary orifice, that is annular level, secondary orifice at the tip of the leaflet, and tertiary orifice between the leaflet edge and the uh, LVOT. So functional obstruction and repair, that is aortic cusp concept. A leaflet behaves like an aortic cusp, that is when it is doming in the diastole. So if it is attached on the three sides, the free edge of the aortic cusp moves towards the center of the orifice when the flow of the blood distends it. That is aortic cusp effect. Doming causes functional obstruction by aortic cusp effect. So functional obstruction and repair, the trap door concept. For a leaflet to move like a trap door, it has to be completely free from three sides. Instead of two leaflets, now it is diagram with a hole which blows like a sail in the wind. In diastole, leaflet edges slide away, but only partially, and continues to look towards each other. That is sliding door mechanism. But usually in commissurotomy, we leave the 5 mm close to the annulus and we'll get an adequate secondary orifice, which makes the valve anatomically open, but it is functionally obstructive. So for this, we have to resect the uh, commissure as shown in the dotted line in the right side, which will give us a maximum area of orifice. That is called extended commissurotomy. After doing extended commissurotomy, we have to close the commissure with a pericardial patch anteriorly in the anterior mitral leaflet, then continuing it to the annulus, then on the posterior mitral leaflet, which is supported by the CV5 suture as described by the author. So subleaflet repair, as described earlier, A is the part where the leaflet uh, attached to the annulus. B is the place where the leaflet is attached to the free margin with the chordae, and C is the papillary. So to have this adequate motion, the subvalvular apparatus has to be freed with the thickening, fibrosis, or a calcification. I will play a video, sir. Class present.
So here is Medanta correction, functional versus diastolic repair. The bottom line, mean rate per 3.14, the traditional 1.5 values statistically significant. So here is the technique. We have deliberately chosen a very calcific valve to show you the technique. The commissurotomy is extended up to the annulus. It's a very thickened calcific valve. Then along the annulus up to the trigone. Then a triangular piece of pericardium, which is glutaraldehyde treated, is inserted. Stay sutures on both sides. One side is attached to the annulus and posterior mitral leaflet. Other side is attached to the cut edge of the anterior mitral leaflet. The base is attached with a CV6 suture to the commissural papillary muscle or its equivalent. The water test is done. And this is the final result. Look at the anterior mitral leaflet. The calcific anterior mitral leaflet is now opening fully like a normal valve with a hinge door mechanism, laminar flow, mean gradient is 1, mitral valve area is almost 3 centimeters square. So that's
So that's it, sir.
You finished?
Yes, sir.
Array, you didn't talk anything about artificial chordae, fenestration of the fused chordae, shortening of the chordae. Huh?
Sir, new
What's
code I have spoken last class, sir. With previous class, I have spoken in detail. So fenestration, this class I have spoken.
no? I think that you spent a lot more time on that mitra clip rather than surgical procedures. I'm not too sure. And then I still am not very convinced with this Medanta type of repair. I don't know.
No,
Sir, you have
this study is still in a process, sir. The author has done only 90 cases till now. Not has done an adequate follow up, sir. So just in a process.
Sir, you have any comments for this?
I'm not sure, do they do such a procedure in our hospital, Medanta?
Uh,
Who is the surgeon in Medanta
Uh,
who started?
Sir, the doctor name is Amit Chandra, sir. Dr. Amit Chandra. He has presented this in last year conference also, sir.
I don't know much about that, The basic principle in open mitral commissurotomy is to get a very mobile valve, So you have to do the incision. There are two ways of doing it. From the orifice, the mitral orifice to the annulus. There's another method, as you said now, the incision starting from the near the annulus towards the mitral orifice. So, Dr. Roy Chaudhary from All India Institute has published a paper. The importance is that when you do a commissurotomy, the the anterior and posterior papillary muscles, they give chordae to both the anterior and posterior leaflets. So when you make a small incision near the annular, it's always better to see that you don't cut the main chordae. So one method is to do a small laryngeal mirror under the, so that you can exactly see where the anterior papillary muscle gives the chordae so that you don't cut that. So you proceed from the annular. The other technique, most people do it from the orifice to the annulus. And we stop at the annulus, this will be sort of annulus. But you said in the Medanta technique, you go along the annulus a little more, and then you with a pericardial, with a gluteal pericardial patch, you repair. I don't know how the
Yeah,
long
yes, sir.
that's going to be. Then the other thing is the basic principle is to get as mobile valve as possible. So you have to sometimes cut off the secondary chordae and the primary chordae fused. You have to do fenestration. And sometimes
Yes, sir.
if
They
you might,
also shaving of the AML also they have
yeah,
done, sir, most of the time.
then the very often in severe mitral stenosis, the chordae is so shortened, it appears as if the papillary muscle is directly attached to the valve leaflet, So that's why you divide the capillary muscle. You have to be careful when doing that, so that the idea is to get as mobile valve as possible. This is what is done. And then do the water test to see the competence. Then you didn't see many of the old things, why there is no quadrangular resection possible on the anterior leaflet. You can do only a triangular resection.
Sir, if we do quadrangular resection, there will be tension on the nearby segments A1 and A3, which will further open up new leaks. Sir. Difficult to.
You do a large quadrangular resection, as Sri Krishna said, you have to always do. You have to cut the annulus along that, sliding annuloplasty. So you have done a quadrangular resection, and then the upper part, you detach the leaflet from the annulus, and the posterior part also is attached. Then you slide so that the annulus comes together. That's not possible in the anterior leaflet. The base of the anterior leaflet is fixed to the aortic annulus, the aortic mitral cut. But you cannot do a sliding there. Then your whole physiology of the aortic leaflet goes up. You can't do that. So in posterior, you can do sliding plastic. In anterior, you cannot do. You can do only triangular plastic. But most of those things have now been replaced with a neocordic, cortex neocordic. Then the only thing is, I think you explained to a little extent. The problem is that most people that I know, previous time, do projected switches on the papillary muscle, take a double arm thing, Gore-Tex switcher, come out, and then another plugette and you tight that. Then you get the cordia onto the edge of the leaflet. Then you feel saline. The most important thing is when you tie, the cortex may slide and the actual length of the cortex becomes shorter, So actually, what P.V. Rao used to do that, you fill saline, the level and the length of the cortex, and then before tying, the assistant holds both cortex switches together, and on that you tie it so that the knot cannot slide more and the cordae cannot become smaller. Now, most of this surgery is done like that. Then I think you should discuss something more about what are the types of rings available, and what is the most commonly used ring. What happens if you undersize the ring? The undersizing the ring may lead to SAM and mitral stenosis. Oversizing the ring may lead to mitral regurgitation. So that's what is the most commonly used ring. What's the most commonly used ring in Narayana area?
The Physio 2 ring is used, sir, most of the time.
Huh?
Physio 2, 3D ring, sir.
Carpentier repair-2 ring.
Yes, sir.
Then there's a flexi ring. Then there is a Costa Edwards ring, which is a dynamic ring, which can be adjustable. There are so many rings. So you say how to choose a ring. There are many methods to choose a ring. The basic
Yes, sir. From trigon to trigon.
There are three methods. One, you take straight switches to the commission, trigon to trigon, two switches there. And then the other method is to have the length of the anterior leaflet. You pull the anterior leaflet towards the posterior leaflet and get the exact length of the anterior leaflet. And the third method is taking the full surface area of the anterior mitral leaflet, So these things are done and then measure. And I read recently a new ring by the Japanese, which has got two rings so that you can take all the sutures. There's an outer ring and there's an inner ring. There's a slot on the outer ring, and you can pass all the sutures and try to see which is the best ring and take that side. As a modern uh, ring tester. This is the other ring tester. There's got two notches at the
Yeah, yes, sir. Yes, sir.
and
Previous
then
class I have described in detail, sir,
yeah,
regarding selection of valves, uh, rings.
and most people select a semi-rigid, and the shape of the ring can be circular, can be incomplete, like a C, or in most cases, like the
T-shaped.
inverted D, the straight part above and the curved part below, inverted D. That's a type of semi-rigid. So these are all variations. If you
Yes, sir.
went on too much on the cardiac catheterization and do those things. There's so many things they do. And surgically, we should have some said more details about the access. The access may be full median stenotomy, minimally invasive, and the endoscopic. That means the VATS or robotic. All those things comes, and then should have, instead of they're not interested, should have described the technique of Alfieri. The basic principle is that in a patient who is not fit, otherwise, to do a stitch, the basic principle is that prolapse becomes less and you effectively make it a double mitral orifice. That's the basic principle of Alfieri. That's the same things that mitral do. And then there are other transcatheter, they do ring insertion through the transceptor. I don't know how it works. And they do a partial
Neocordial insertion.
ring, partial ring through the coronary sinus. I don't know how it works. And that's the thing's minimally invasive transapical neocordi without cardiopulmonary
Ah, yes,
bypass.
sir.
Minimally invasive, minimal incision. And then you get the apex of the heart, and on a beating heart, replace the cord. I don't know how they do it, but this technically, theoretically, these are the things. And the new Japanese, Toru Asai's butterfly technique, which seems to be very good for isolated prolapse of the posterior leaflet, butterfly resection, and
Yeah, yes, sir.
symmetrical position. Without using a ring, you can do that. There's no scare of a SAM in such case. You should have got, I should have described what exactly we do in this hospital. I think Dr. Rao has been doing mainly the neocordia, cortex neocordia. That's why he said get somebody who does this regularly, or at least before you could have discussed the details and come and presented that. If they are not able to come, at least you can discuss with him what exactly is preferred and what's done in our work. Okay.
One thing you all must remember is this is a very delicate procedure. The tissues are very delicate and your measurements have to be precise. That is why not many people are able to produce good results. Okay. And you have to learn the proper technique from proper people who are doing this regularly. And that is very important. Now, one practical step that I can tell you about the open mitral commissurotomy is that you generally take two stay sutures on the anterior and posterior leaflet at the commissure, put a right angle underneath the commissure, and then you can always see a raphe where the two leaflets are fused. And then from the KM technique, we used to use the back of the knife not the sharp edge. The back of the knife of a 15 blade, and gently scratch over the raphe so that it slowly gives way and progress right up to the annulus. If you try to use the sharp edge and incise, you may create a false passage, and that will be a disaster because the subvalvular structures will not co-opt properly. So this is the technique. I'm sure Sanjay Dade would be doing such a thing because this is what we were all taught, how that is to be the standard procedure in KEM. So that we used to do a lot of open commissurotomy and things. And as Sir said, alveoli stitch is making a single mitral orifice into two by a central stitch. You must remember that this is a temporary thing. It does not eliminate MR. It will only reduce the regurgitant volume. The MR will still persist in spite of the alveoli stitch. So that is what you have to understand, and that it is a palliative procedure rather than a curative procedure. And that is the same thing that is being used in the mitra clip, this thing. And again, I'm reinforcing that it is only done in somebody who is unfit for a surgical procedure. That is the thing that you should remember. And the Medanta technique still has to be proved by many people, and I don't think you should be talking about it until it comes into publication. And just because they presented it in a conference doesn't mean that it is an accepted procedure.
What's
Okay.
caudal transfer? What textbooks describe, it probably may not be practicing it, caudal transfer.
So the transfer of secondary chordae near to the margin, less than 5 mm, can transfer the secondary chordae to the primary position. And
Not secondary caudal. Suppose there's a caudal rupture, you can reflect that in the posterior leaflet, the anterior leaflet, and you take a small same amount of anterior leaflet, the square piece with a primary caudal from that, and that is brought back to the resected part of that leaflet, and the other leaflet from which you have taken the chordae along with a small square piece of the leaflet, that is directly sutured. You have to select where you can. You can't do with secondary chordae. You are transferring the little bit of leaflet with the primary chordae. That's what is done. For a caudal rupture, they used to do it. I don't think they do it nowadays. They instead of put a new chordae. Okay. Caudal transfer done much nowadays.
One suggestion I have for all you guys, who is working with Raghu nowadays?
Kritika is
He's
there.
got a
Sir.
fellow, right? Fellow for MICS.
Yes, sir. Atul
But-
sir is there. Sir.
Yeah, but there is another person. So what I would suggest is somebody who does repairs regularly. Somebody should do a headlight camera, record a video of the various types of repairs that are done, and so that you have a ready reckoner sort of thing for your own learning. Leaflet transfer, leaflet this thing, augmentation, open commissurotomy, triangular resection, quadrangular resection, sliding plasty. So you have 2-3 minutes clips. Make teaching videos for yourself and for the future generation of students who come after you. So try and do that, and then I can coordinate those things, and then we'll have a library of these sort of things, videos. It will be useful for everybody. Somebody take an initiative and do that. I'm sure we have headlight cameras, no?
Yes, sir. We have, sir.
So one of you should take the lead and then talk to the surgeons, talk to this thing, sir. We want to make a video of this for teaching purposes, and then I'm sure Raghu will oblige.
Yes, sir.
Maybe I will talk to him also myself. Okay.
Yes, sir.
Are the Chennai fellows participating nowadays?
Yes, sir. They are taking part, sir.
Okay.